So I know we did a land acknowledgement this morning, but because we're starting again this afternoon, we just want to acknowledge that we are here on the Cunyahaca territory, which is the, when in English we would say Mohawk. And in particular on the island of Montreal, it's the Jogje Way land. And this is a land that has been known for millennia, hundreds of years at least, millennia probably, for being a conversation place, a meeting place for many, many different nations. And so it seems like a very opportune place to be, to have this kind of discussion with the diversity of people in the room with us today. So we'll just give a little bit more background, less the professional or an expansive version of introductions for ourselves. So as noted, I'm a professor, but I'm also an immigrant to Canada, originally from the United States. I did my PhD on the subject of equity in healthcare financing and healthcare services use, so I have a long-standing commitment to equity and considerations of diversity in the use of data, but I'm definitely also a quantitative-oriented researcher, working a lot in policy evaluation and really trying to see how we can think about the intersection of population health and health services research and make sure that everybody has an equal opportunity to choose the paths they want in their life here in Canada. So, Elise.
So, as you know, my name is Elise Maybee, and I've been a patient mostly because I'm accident prone, so I've seen a lot of the acute care system, but I also had a mother who suffered from dementia before she died, but she was in the Netherlands. I'm half Dutch, and so I got to know the Dutch system as well. My background actually is in technology. I spent years designing and implementing systems that were poorly informed and very reluctant users. So I can see there's some parallels to healthcare. I've also been involved in a lot of digital health projects as a result at every level. And as I said earlier, I've been a member of the expert advisory group, which really focused me on the whole question of data. And we'll talk more about that as we go on. But I think more importantly, I'm what they call a patient partner, a patient caregiver partner, and have been since 2011. I've been on tons of different research groups. I've been in research management. But in that journey, I also got together with 12 of my colleagues from across Canada, and we pulled together the Patient Advisors Network, which is an independent group of patient and family partners, advisors, so that we could learn from each other how to be good at this job, because I consider it something of a job. But it's also given me a deep connection to people who do this work across Canada, and some insights as a result of that. So I think I'll end there. So.
Great, thanks. So Elise and I have planned some opening remarks, and then we're gonna have a bit of a conversation. There'll be lots of time for engagement with you following that. And first, what we wanted to do, I'm not gonna go there quite yet. I actually, do we have the polls, David? Can we? Yeah? Okay, so I don't know if all of you in the room, so I'm gonna ask this so the people in the room can just raise their hands, but we have this first question that how healthy is the culture of healthcare systems? So for those of you who are not plugged into Slido already, how many of you think that the culture of the health and health data are very, very healthy? How about medium? How about not healthy? Okay, so, and that I would say is maybe the people in the room are tipping even a little bit more towards the not so healthy end of the spectrum on that one. Okay, second question, there's 3 of these questions. The second question is, how would you rate the transparency of what data are collected about you and how they are shared and used? So on transparency, are we ready, guys? Very good. On transparency, how many of you in the room think we have very transparent systems? Okay. How about moderately transparent systems? Okay, we're going to get a few on the moderate. And how about not very transparent systems at all? Okay, again, roughly similar in the room and online.
Yeah.
And I'm going to go straight to the last one. How much trust do you have in health data? So in the room, how many of you have a lot of trust in health data? How about moderate amount? Okay, we've got lots of people in the moderate. And how about not very much at all? I wonder if that would have been affected by our first presentation this morning. So we have lots of work to do in this area of culture, transparency, and trust. Okay, so we're just going to do a little bit of setup. You know, where did the Pan-Canadian Health Data Strategy come from? And this probably doesn't need belaboring at this point. These are headlines picked from newspapers during the pandemic. And it was very clear very quickly that we did not have the data we needed to run systems, make decisions, and particularly in the context of an emergency, the way we needed to do.
So the question is, why should we really, as a member of the public, concern ourselves about health data? And it's essentially because we are the data in the system. The data represents the essential ingredients that our providers, our clinicians need to figure out what's wrong with us and figure out what to do about that. It is the basic tool of their trade. And so as an individual, of course we should be concerned. So now our collective health data, which get lumped together or aggregated, are also important. And this is the data that we use in health systems to make it better for us, or supposedly, by policies and practices that will advantage the health for all of us. It's also used for consent in research, so that we can ultimately lead to better treatments for different targeted populations. So then, as a member of the public, we also understand that aggregate health data is important.
So what happens when we don't have our data organized in a reasonable way? Well, one thing that happens is that we make people responsible for their own health data. And for anybody who has any significant or even maybe moderate health conditions, what this results in is either you or a family member carrying around your binders with you. So to actually have a term that is commonly used in research called binder medicine, which is ridiculous in the fact that we would actually need to have a term for something like that. But that's one of the things that happens. At the aggregate level, where we're trying to use data for research or planning or quality improvement or whatever it might be, the challenge might be that the path isn't clear. It's not very obvious to us how we might actually be able to get access to the data that we need. Even more to the point, in some cases, depending on who you are and what position you hold, there may not be a path for you at all. And I'm thinking here about community groups or nonprofits or charities, and even the private sector. It's not always obvious how we get access to this. So it's difficult for researchers and impossible for others.
So this says it all, really. Every system is perfectly designed to give you exactly the results that it gets. And as you can see by the image below, that's kind of where we are today. So I have a couple of thoughts about this. Firstly, especially during COVID, the private sector really ramped up their offerings. And I have a number of friends who jumped to the private offerings because they weren't getting what they wanted from the public system. And I think that none of us wants to see an erosion of the public system, but we really would like to see it adopt some of the features that we already expect from like banking and Amazon and all of these things. That has really set a bar for us. The second thought that I have here is that we need to transform the system, and the public really needs to be involved. And for that involvement to be robust, the public's going to have to understand more about the system. I think most of us don't understand what's behind the curtain, in the case of the Wizard of Oz, if you will. So we're going to need to look at a greater literacy for the public so that the decisions they help us make as decision makers, policy makers, and so on are going to be informed. And why should the public get involved? Well, first of all, we pay for the system. We experience the system as a system or non-system. And so therefore, we should be involved in helping to co-design any changes. Do you want anything, Kim?
Probably add a lot on this. So, I mean, go back to the culture question. It's pretty clear that if we're going to want to achieve some of the things that Elise is talking about, this is going to be a massive change. This is not an incremental change, and a lot of the change is cultural. It's also important to recognize that the data, when we're talking about data reflect systems, and if we want, if the data are telling us things about inequalities and inequities in people's experiences, it doesn't mean we need to change the data. We actually need to change the systems in order to make change for people's lives. And this is going to include sharing power differently than we do now, with more ability for a greater range of people to actually have influence on the decisions that are made and the shape that things take. So this kind of goes then to the first recommendation and then the third report from the expert advisory group in Pan-Canadian Health Data Strategy, which this vision being that by 2030, all people living in Canada will benefit from a fully integrated, continuously optimized learning health system. And I'll get to the second part of that in a minute. But the idea here is that learning systems, or learning health systems in this case, are systems that are structured to be able to take every bit of care that's provided, turn it into information or data or something that can be used then to make it better, to continuously improve for the next person that comes along. Some of those things may be small, some of them may be bigger. But then I want to reflect a couple things from the conversations we've heard earlier today, which is, one, that all knowledge is relational. I think it was Harlan who said that. And that is true in the sense that we need to have each other and the perspectives of many people in order to understand what we need to change and improve. So a learning health system doesn't work if only a narrow group of people are involved. Learning health systems also need to be designed for inclusion, not designed for the average. And I loved the quote from Audre Lorde, and there's another piece in that same short piece that she wrote that was quoted this morning. And what she says is that difference must not be merely tolerated, but seen as a fund of necessary polarities between which our creativity can spark like a dialectic. Only then does the necessity for interdependency become unthreatening. Only within that interdependency of difference, strengths acknowledged and equal, can the power to seek new ways of being in the world generate, as well as the courage and sustenance to act where there are no charters. So we're going into uncharted water. We need all of us to be along in that. And if we're going to actually make learning health systems a reality, we're going to do that, and we're going to need to consider and embed and use context as well. So just a couple quick things on the charter. There's 10 principles in the Health Data Charter. I'm not going to go through them all here, but they start and end really with this idea of person centricity, that every decision we make about health data needs to be considering putting people at the center of it, not even just considering it. It has to put people at the center of it. And we need to include a lot of diverse voices in shaping what those data look like and then who can have access and use them over time.
Yeah, so I'm just going to jump in here because we talk a lot about integrated team-based care as being sort of an ideal model of care. And it may well be, but it needs to be underpinned and supported by a data system that will do that. We don't usually think about the infrastructure when we talk about these models of care, but we need these infrastructures to make them a reality. And a person-centered health data system is absolutely vital if we're going in this direction. One of the things that PAN, the Patient Advisors Network, has done recently is we have just produced a report for CIHR called Reimagining the Research Landscape. And part of that was that we really learned from our community that the people who are involved in health research are, generally speaking, the favored few. They're people who look like me, often white, female, older, and reasonably comfortably off. So why is that? And that is partly cultural and I think partly systemic. But if we're going to redesign systems, we need to be able to reach into the tapestry of diversity that represents the people who live in this country. So how do we do that? Over to you, Kim.
I don't know how we're going to do that. Did you want to say anything more on culture before I...
Sorry?
Did you want to say anything more on culture?
Well, we're just about to dive into culture here, so yes, I do, because I think it's fundamental, and actually what we found in our report, which was a bit of a surprise, as we hear a lot about things that, like, I wasn't listened to, I was a token patient partner, and so on and so forth, but essentially, they are all actually symptoms of a deeper condition, and that condition, when we did the analysis on all the feedback we got from over 262 people, is the culture, the underlying unconscious culture, workplace culture of health research. And it is, it supports the problems and symptoms that we see. And when the favored few, people like me, are feeling like outsiders, and the vast majority of people who responded feel like outsiders, then we'll never get to diversity if we don't address the underlying culture. So a couple of things about culture. Right now, our healthcare culture writ large is provider-centric. It's not person-centric. And that's a real problem, because if it's provider-centric, then it allows for our information to be in different buckets per provider. I must be in 15 or 20 different buckets. If I ever want to understand my health landscape, I have to hop from place to place, if I can even do that. So when you have a provider-centric system, then the accountability for the whole person is difficult, if not impossible. We may expect that our family doctor can do it, but they don't even get all the data. They don't even have all the understanding. And we heard this morning from Antoine and so on, that the context isn't there. And the context matters greatly. Whether or not you have a caregiver matters greatly, or housing, or a job, or food, all of those things. And those pieces of information, as Antoine said, aren't buried into the EMRs. And so the physicians, our clinicians, are flying a little blind there too. The other element of culture I just want to raise, this is our current state. So we're just looking at the current state. The current state is the culture of exclusion. It's not a culture of inclusion. And I've seen that when I was last in hospital in particular. There's a hierarchy of healthcare workers, and they are not all considered members of the healthcare team. So the people who dropped my food off, the people who cleaned the room, they were not considered part of my care team, and yet they contributed to my care, or certainly desired to, and they understood things from what was happening while I was there that they could have shared with the rest of the team, and perhaps there was no real mechanism for them to do so. So why are we pigeonholing people who work in healthcare like that? And then, I've also seen that this, along with the hierarchy, there's a lot of shame and blame, and we were talking about the need to have an open culture, a learning health system. You cannot have a learning health system if you have a shame and blame culture, because nobody's going to speak up. And you need to be able to fail fast and learn from failure to have a learning health system. If you have a shame and blame culture, it flies in the face of a learning health system. So on the other part of exclusion are patients and caregivers who are actually considered outsiders or objects in the system frequently. Not always, thank goodness. But we are considered outsiders, and in a lot of cases, we're not part of the care team. And then if we look at those of us who've elected to become patient and caregiver partners, we are considered outsiders. We feel like we are treated as outsiders in the vast majority of times. We need to change this culture of exclusion. We need to understand the unconscious cultural drivers that cause us to be outsiders. And so how do we do that? How do we come into a future state?
Well, I actually, if you don't mind, Elise, I would love for you to, and I hope you're prepared for this, but to riff on a bit on the report, the PAN report you were talking about, and the research culture as well, because you laid out the patient care culture very well, but I know your report says quite a lot about the research culture as well.
It does to a large degree, but one of the great things that has happened, that the report has gone out there, and we've heard back from many of our researcher colleagues, and they've said the sense of being an outsider actually resonated heavily with them as well, and that there is a bit of a sense of being an outsider even as a researcher. So I think that's there's a lot of cultural issues that we can examine and look at and see what we can do about it.
Okay, so with that, I'll talk a little bit about the future state. So, I mean, one of the best things we can do if we want to get to a different future is actually to recognize the messiness and the drawbacks and shortcomings of the situation we're in now. So that's one thing. And it's not just one thing. That's one thing to do, but it actually encompasses many, many different strands of activity and areas of messiness, as Elise was talking about. Which means that one set of approaches, one silver bullet, one thing to be done is not going to work. We're going to have to do lots of things all at the same time to try to get systems better and to try to make data better to go along with that. And Lisa and I actually had a little bit of a back and forth about, do you make data systems better, and through better data systems we can actually provide more integrated and better care, or do you make care systems better and then those better care systems will produce better data? And in the end, I think we believe it's probably both, and in those cases we'd have to try to do both of those things. And so the secret weapon in my view on this is it is public involvement. It is bringing people into the system and actually trying to make the system feel more accountable to people, and that's a theme that we'll pick up a bit later. I just want to talk about the kinds of public involvement and the ways to think about doing that I'm talking about. And so just for a hand show for people in the room, how many people have either heard of the IAP2 spectrum for public involvement or Arnstein's ladder of public involvement? So maybe a third or so of people. So the idea of both of those things is that there's a range of options that we have for how we want to think about how to bring public into the conversation. I'm actually going to talk a little bit from what Sherry Arnstein wrote in the late 1960s. She uses the idea of a ladder of public engagement. And I like her description of this because the very bottom rung of the ladder is manipulation. And I think it's a very fair thing to note that public involvement and public communication, or public engagement as some call it, can be used to influence people through, I mean, I think we all know this now, disinformation, bad information, distorted information. So we need to stay away from that, obviously. But beyond going to that route, you can involve the public by having a website and making things more transparent, sharing information. You can involve the public by doing a survey and asking for their input, but without any guarantee you're going to do anything with it. You can involve the public by having a focus group and getting a little bit deeper information, but again, not necessarily committing to using the information in any particular way. You can involve the public through deeper engagement and a commitment, and at the very I don't know, you can say top rung, right side of the spectrum, you can actually transfer power and give power-making authority over things like how data might be used to the public. And I want to emphasize in saying this that all of those things are needed to some degree or another. So this is not to set up a situation where we think that only one approach to public involvement or engagement is needed at any time or over all time. The importance, I would argue, is that we are deliberate and clear about what tool we're choosing for public engagement or involvement, why it's the right one for the thing that we're doing now, and how we're going to actually live with the principles that we're embedding in that. So we're not going to have a big deliberation with people where they're going to be making policy recommendations, for example, if there's not somebody who's willing and committed to implementing, or at least seriously considering the policy recommendations that are coming forward. The other thing I just want to caution against is that if you think about transferring power to people, you could immediately think about all the technology that we have available to us now, and shouldn't we just give people lots of control so they can make individual level decisions about how their data is going to be used. We can consent or not consent and that sort of thing. And I would say that, yes, consent is important. We can have a whole conversation about that. But it's not the be-all and end-all. We use lots of data in the health system that aren't consented. They're collected by authority, not consent. And furthermore, and I would say more importantly, data embeds social relations. They tell us something about ourselves, but they tell us something about other people like us. Genomic information can tell you something about your family members or your community members, and they tell a lot about how we relate to one another. So it is not really, when we're talking about especially population-based aggregate data, we're not really just talking about the benefit or the risk to an individual. We're talking about much, much broader things than that societal level in the ideal situation. Did you have anything you wanted to add there?
Not specifically at this point, but we were going to get into sort of what citizens groups would look like, and I thought maybe you were going to lead on that one.
Okay, so if we go to the deliberation end of this spectrum, one of the things that what happens as you move from one piece to another, you can see when you put out something on your website, absolutely everybody who has access to the internet could possibly see that. If you do a survey, you might be able to survey thousands and thousands, or maybe even tens of thousands of people. Or if you're Statistics Canada, you survey absolutely everybody in the country. When you start talking about focus groups, you're talking about much, much smaller groups of people. So there's a trade-off between the kind of information you can get and the number of people who are actually involved in providing that information. So when we get all the way to what I have done some work in, which is deliberations, we're usually talking about spending lots and lots of deep time with a relatively small number of people. The Irish deliberation has been used, and particularly around the referendum about abortion, has been used as a bit of an example where they brought 100 people together, gave them good background information, gave them access to people who could answer questions and give additional resources, and then let them have a conversation. Because the idea in a deliberation is not to make people into experts of one form or another, it's to give them enough information to be able to have an informed conversation with a diverse group of people who represent as many views in society as was possible to fit into 100 people in a room. So when you have those kinds of conversations, what we're really trying to do is to say, not what do I want myself as Kim McGrail, but given that we live in a diverse community with lots of different beliefs and values and worldviews and so on, how do we create rules that everybody can live with in a reasonable way? So that's the power of a deliberation, is it allows lots of deep conversation, an understanding of trade-off, and for people to be able to voice collectively the recommendations that they want to put forward. It does come with the idea that you're only being able to do that with, 30 to 100 people at any one time, because the scale of it just gets a little bit unwieldy.
Yeah, so then the big question is, how do we do that in Canada, where we have a huge geography and a small population and something like 14 different health jurisdictions? So that would be a big discussion, I think. The other question I have in my mind, and I'd be interested when we get to the Q&A on people's thoughts on this, is what role do the existing patient organizations have? I mean, we have the Patient Advisors Network, PAN. It is completely independent, so that's one organization. The other patient organizations tend to be tethered to a host organization and serve the interests of the host organization, but they too could play a role. So those are all different aspects of it. Should we have a tiered approach so that we have maybe regional councils that then report up to a sort of a federal council? There's a lot of thoughts I've had about how we might structure citizen involvement in decision making. Now, I just want to take a quick segue here because it relates, and that is, how do we tap into diversity? I've been privileged to be a co-initiator of MPACT, which is a community table of a number of us who, most of my colleagues are from very diverse backgrounds, and we've come together to form a table to do consultations on health equity. The interesting thing about that table is it was created by patient and caregiver partners, and we have people coming to us with policy, research, and practice work that they want a health equity lens from our group. So they come to us. We hold the power to accept or not accept, to work with them, and then we give them the recommendations to make their work more equitable from a health equity point of view. So it's a very interesting model of sort of flipping the power dynamic, and we were talking earlier about power dynamics. What can we learn from that and from a lot of the experiments and the efforts that have been done, particularly with First Nations and Indigenous communities, of alternate ways of working together, of collaborating, that are outside the status quo, where we're invited in as individual patient partners on terms that are set by the professionals. I just want to segue now to the whole question of accountability, because the question I have is, who is accountable to whom and for what? In the end, as a member of the public, and since we pay for our system, should the accountability not be directly to us? And I know in a way people will say, oh yeah, well, you vote and those guys are representative of you. That may be true to some degree, but I think there should be perhaps a more direct accountability. And if we had a citizen forum, perhaps an accountability could go towards the citizen forum. And then the question is, what are you accountable for? And for me, it is patient outcomes and patient experience. Those are really, in some senses, the only two really important factors for those of us who are members of the public. And so, is the experience being improved by whatever? Is the outcome being improved by whatever? So I got some other musings here, but again, with the sort of learning health system and the understanding of accountability, if we're also looking at accountability, I'm jumping around a certain amount here, if you'll pardon the hopscotch, but one of the thoughts I had too is, I would like accountability for my data, but I can't see my data in most cases. I can't see the notes that are written about me. I don't know whether what's in my provider's notes is accurate. I know one provider called me a hysterical woman, which I take great offense to, the hysterical part, not the woman part. And, you know, is that in my record? Is it there indelibly? What does that mean for other providers that see it? Or do other providers see it? Somehow or another, as members of the public, patients need to be able to see their records, and they need to have a process by which they can correct errors of fact. I have a colleague who had one kidney removed and was so annoyed because they marked the wrong kidney in her record, and she could not get them to change it. Can you believe that? I mean, how silly is that? So I think this is, the quality of our data is really important. And I think that as patients, we can contribute to the quality of data if we had eyes on and a mechanism to make sure that it's in good order. So I think I'd like to talk briefly now about literacy. How do we prepare people to take this role? Do people even give a darn? How do we get them to give a darn? So that's a whole awareness thing. You know, do people even understand that this is a thing that they should be concerned about? I know for many of my colleagues who are patient and caregiver partners, they will say, oh, I experienced this terrible thing from this provider or from this organization. But they don't understand that perhaps why they experienced it was because the system didn't support the organization or the provider. So they don't know what's behind that thing. And I think there has to be a way of teaching people about that. And so that's the awareness question. And then I think there's a whole nother question over how much we need to know. We don't need to be experts, but we do need to be informed human beings. And we all know in a democracy, if you have a fairly well-educated citizenry, then people are making more informed choices when they cast their ballots. I think this is very similar. So.
Yeah, so you can see when we talk about this culture, transparency, and trust, they have a lot of different kinds of relationships to one another. Elise has been talking about both accountability and literacy. So I'm going to just kind of start zooming us to the end so we make sure to get a lot of conversation with you going. I mean, part of transparency is kind of embedded in this cartoon shown here, which is that it means showing your work and making that visible to other people, saying what you're doing and why you're doing it, and letting other people see that. In the world of research and secondary use of data, it is kind of going back to that idea of consent as well. Did I give you permission to do what you're doing? Are you doing the things that I asked you to? Now, and again, this could be about individual consent, but it could also be through a public deliberation or the other kind of method coming to this idea of broad consent, which is that, yes, ideal in some sense would be that, yes, as a group of people in Canada, we want to see our health data used in these circumstances with these guardrails by these people for these purposes. We should be able to define that and actually give somebody some direction about what collectively we think is okay without further consultation, and where there needs to be further consultation because there may be some things that we might need to consider in addition. And I'm sure some of that will come up in the AI discussion this afternoon. So if we go from there to thinking about trust, I love this quote from Audrey Tang, who is the Minister of Communications and Digital Communications in Taiwan during the pandemic. And what they said is that it's incumbent on the government to show trust in people and not vice versa. And the more trust the government has in its own people, the more deserving of trust they become. So in other words, first of all, again, a relational kind of notion of trust here. If you want me to trust you, you need to trust me, which means making things more visible to me. It is also about making sure that the first mover is honestly the one with the more power, which clearly in this case will be governments and other groups that have the data that you want to be worried about. In trust, I think that there's two important elements, at least, and one is trusting in the process, which we've just been talking about, and then trust in the actual data, which Elise was mentioning earlier. And this just comes down to an important distinction that we trust something because they have shown themselves, this is a person, an organization, or a system, they have shown themselves to be trustworthy. So it is not right to say, if I tell you more, I know you'll trust me. What I have to do is act in a certain way, earn your trust, and then hope to keep it. And then, of course, the aphorism there is that trust comes in on the back of a turtle and goes out on the back of a horse. It's very hard to gain and very, very easy to lose when something goes wrong. So Elise, anything to add there before we open things up?
So just thinking about trust mechanisms. Well, first of all, my thought about trust is trust is a byproduct of transparency and culture in many ways. So I just, I don't think it's sort of like happiness. Happiness is a byproduct. It's not a thing that you can achieve just by focusing on it. And I think trust is the same way. There are also mechanisms for trust. And so when we talk about sort of co-designing a system, if as a citizen you feel that your colleagues, your other citizens have been involved in co-designing the system, you're more inclined, I think, to trust it than if it was delivered from somebody on high. So there are some mechanisms that can engender trust like that. I think awareness, the transparency is clearly a mechanism for trust. Yeah, and agency, making sure that the citizens who do get involved have agency, have some degree of power. They're not just there as a pretty face, so to speak. Okay, so I think that's all I want to say, but I think it would be really exciting to hear from the audience.
So, Maureen has her hand up. Stella's behind you. Yeah.
Thank you. That was a very thought-provoking presentation. Just on the last thing you said, Elise, about trust. I had the privilege of listening to about 8 hours of Ontario citizens talking about our health system, and that's exactly what they said. If we thought that we were at the table when some of the policies were designed and we were participating in that, we would definitely have more trust in the system and in the policies. So, right on with that. But my question is about quite a while back. You talked a little bit about the role that patient organizations have, and I'd like you and Kim's opinion on that. What I've noticed is a tension that sometimes exists, not always, but sometimes exists between when we talk about representation or the perspectives of the citizens and the public, we'll call them the public, and of patients. And I've been in this space 25 years and I've worn both hats at different times. So when I'm in rare disease, I'm a patient and I'm bringing that perspective. But I'm a big proponent of public engagement too, and you're using the terms back and forth, and you're the founder of the Patients Advisory Network. So I thought it'd be really interesting to hear your perspective on that. And is the pandemic moving us more into talking about more public engagement because of the health crisis that we're still in, but that we really experience in such an acute manner? So,
well, thanks for that, Maureen. So, I've thought about this a bit. I don't think I have any sort of crisp answer for you, but in some senses, patient and caregiver partners are the committed members of the public who have chosen to engage with the health system. So they're almost like the advance guard. And if we look at it that way, I think one could engage with groups of patient caregiver partners to help co-design public engagement and to help work with other members of the public to do that. That's just sort of off the top of my head, kind of how I see it, that you have knowledgeable people who are already invested that can help engage with those who are perhaps don't know that they don't know or should know. right?
And I think what I would add is that similar to the spectrum I described, or the ladder, and being deliberate about choices, I think it's really, really important to be deliberate about the choice of whether you're engaging people with lived and living experience or general members of the public. You will absolutely get different answers from those groups depending on what question you're asking and under what circumstances. So the point is not that we should pit one against the other, or that the one choice is always better. It's to be very, very clear and deliberate about putting together the group that you want in order, and I don't mean hand-selected, I mean choosing one of those options when you're, depending on the question that you're trying to address.
Okay. Thank you for that. Thank you for the question, Maureen. We're going to go online to a question, and the question reads, how do we improve data literacy in different populations? Do we just care about data literacy for the public? What about data literacy for policymakers, et cetera?
Oh, thank you for that question. I have been involved in a number of groups that actually lump together trust and public literacy in a way that I think is very unhelpful, because it assumes that if we just tell you more about what we're doing, you're going to trust us, that there's a direct connection there. It also assumes that the public is the only group that needs literacy, which is absolutely not the case. Here's all the groups that need literacy. Politicians, that would be great. Decision makers, policy makers, providers need a lot more literacy than they have. Researchers, frankly, need a lot more literacy than they have, especially when we're talking about diversity and that kind of things within data. So this is a universal need. How do we do it? I mean, we've talked, Elise and I've had long hours of conversation about this, all the way back to thinking about we need to do with health data and lots of other financial literacy, all sorts of other things, what we did with media literacy, and actually put it right back into the educational system starting in elementary or junior high or high school. So what do you think?
Well, I just laughed at this question because I had the dubious privilege of talking with a policymaker who had designed a sort of a fairly large system change and was, very proud of it and so on. And all I could think about was all of the places where it was just not working, and how whoever had designed it had never gone through the system. And sure enough, he had never gone through the system. He had never been on the front lines. He had never done any of that. So he had no idea. He just designed this thing in a vacuum, in my opinion. And so there's a real disconnect, and I think, for some policymakers, that they just they don't engage in the front line. There's a lot of literacy that can happen there as well.
Thank you. And we have a question. I see a question. Oh, the microphone's right there. There we go.
Thank you. Well, thank you for this lovely talk. It's very inspiring. And regarding the trust and participation of the public, I would love to share my experience as a 20-year-old nurse in the field. I've been able to participate in different instances where the public make their own decisions, such as the Palliative Care Council of McGrail here in Montreal. And they open a window which is very nice, because they allowed people to, they already experience the system, to teach new people on the system what they need, what their options. So they gather just not about the public, but as well physicians and healthcare workers. So there's an instance that we all share our experience and how to teach people how to navigate the system. And because how we do trust, how we start opening the window for people to trust, is start with smile. Actually, is start with listening what the people needs and acknowledge that we cannot say just, okay, you're gonna need this. No, we need to know what they need, acknowledge that, try to do something about that, and then we can move forward. And there's a lot of instances as well in the Jewish hospital, for example, Hope and Cope. They do the same with people with cancer, that they teach them how to navigate the system. And we always said, I am going to leave you drive, like you're gonna drive, I'm just gonna move the rocks out of your way. And that model is where people start trusting more the system. Thank you.
Could you kind of recap that just a bit?
Yeah, I'm going to ask you if you could you summarize it? We faded out just a little bit with your microphone, so we missed some important things you were saying. Could you maybe, when you speak, just hold the microphone right by your mouth, and we'll be able to keep up with you. So I apologize for not catching
I'm
it.
so sorry.
Perfect.
Yeah, no, I just wanted to share my experience because you were talking about how the instance that we can make people to trust the system. And to not forget the system is not just something ethereal out there, it's people. It's people smiling back to you after you talk, after you need something, they acknowledge. So how we do that is actually human contact, right? And I've been participating in different organizations, which is the palliative consult care at McGrail, where they being able to have an instance of sharing with the patients and learn, teach them how to navigate the system with people that are already been using the system. Because when someone face someone's death, okay, for the first time in their families, they don't know how it works. They don't have to know it, but to have an instance from the public and mix it with the healthcare team to teach them how to navigate and acknowledge what they need and how is the trust relationship starts.
Would one of you like to comment on those comments?
Yeah, I think I'll just say it's a great point, and I think it's very consistent with what we heard this morning from Antoine and Farron. So I think that, thinking about who can be the intermediary, how do we connect people, how do we help them? The only drawback I would see, it's not a drawback, I shouldn't say it that way. We need to be thinking both of providing those kinds of connections at an individual level, but also thinking about at broader levels how to increase that knowledge and experience as well, or to make the system more rational so it's easier to understand. That would be another option.
Yeah, I think so. I mean, one thing that struck me when I was listening to Antoine and Farron talk this morning is that was a very individual thing. So what do we need to do to support it systemically? And amongst other things, I think if we lose fee-for-service, then we support physicians in taking the time to actually consider the whole person, to look at the context and so on. So that would be a systemic change that would help support the individual change that's needed.
Great. Thank you for that additional commentary. I think we have the time for our final question, and I think the microphone is right there. So we're down to our final question, our final 3 minutes here this afternoon.
First of all, Kim, I think you missed private sector when you were going through the list of who needs to get more education. To your question about patient organizations, well, the first logical thing that they can do is pass out information that you want passed out to the people they deal with. But I think there's another thing, and it's about trust. I think real patient advocates are the ones who earn trust over time by speaking about what's important to patients, notwithstanding the hosts of their work. And that's a time thing. And the last point I'd like to make, we've kind of got our house burning right now, and I know that you'd like to take a lot of time and change the culture, to Kim's point. I think I would start by telling the public that the house is burning and educate them that doctors don't have your records, and if they don't, you're not going to get good public health care. So I'd actually start there and then keep working on the others, but I'm not sure we have time to change all of our cultures of all of our stakeholders.
Thanks for that, Louise. I agree with you. I think it is a very sort of critical point, and I think we can use, in part, the, if I could dare say it, the advantage of the things we've learned from the pandemic, because people have been viscerally experiencing some of the gaps, if you will, and the downsides of our non-system. So they're more aware of it than they have ever been. So there is an opportunity at this point. The question is, who is going to do that, right? And that's really the challenge. And we aren't seeing it out of the media the way we might want. We're certainly not seeing it from governments because they're busy butt covering like crazy. So who's going to take that banner and run with it? I'm afraid it's going to have to be the patient organizations. And so we'll talk.
If I can, Bill, I just want to add one quick thing, which is I agree that we need to prioritize. This is like, we're going to do culture change. We can't do all the things right now at the same time and think. On the other hand, we will not get lasting change if we do not actually fundamentally change the system and the culture around the system. So we somehow need to, as they say, walk and chew gum at the same time.
Yeah, we need to run more than one horse in this race.
There's two beautiful analogies right there. Okay, so we're going to go to our final. This is definitely our final question in this session this afternoon. Frank.
The question is around. We heard this morning, about context, and there's been lots of talk about linking health data to data around employment, housing. The environment even. I read something recently about how our brains are being affected by the climate change. The question is choices. So the question is, what kinds of social data most need to be linked to health data? My concern is that people like Farron made a very good case, but people like Farron have very little political power. And we have power systems. We have people who have a lot of power. And my question is, given that we have limited resources, where do we? My worry is that people with Fitbits, which are very valuable, but is that the kind of data we most need to be incorporated, or are there other data and data that are important to perhaps people who are especially disadvantaged and whose needs are greatest? So how do we decide this when we have most of our systems, as you indicated, Elise, people, middle-class people and so forth are very well represented in some ways, but maybe, the data that is most pressing is data that is important to a portion of the population that is least powerful. So how do we address this issue?
So if I can just jump in, and I'm sure you'll want to jump in too. There's a lot of data from StatsCan that is often used for that, and there is other just sort of straightforward survey data. I don't think Fitbit will do, because if you're thinking about homeless people, they don't generally have Fitbits. So I think we're having to look at where there is actual data. There may be data in other ministries as well, like when you think about housing ministry or so on. I don't really know. But I do think that we need to bring together social services and health, because if we're ever going to move to more prevention, the prevention is in the social determinants of health arena. And so we would have to bring them together. And that may mean sort of a structural bringing together plus a data bringing together. And that's, I guess, just my thoughts.
Two very, very, very quick things to end this. One, we need to use data linkage, as you're talking about, to understand population level, who's falling through the cracks, are certain groups suffering more than others, what's missing. We need to do what Farron was talking about this morning, but I'll expand it a little bit to the things that physicians, other providers, primary care need to have in a shared health record about individual patients. We need to figure out the short set of questions that we can ask. Do you have enough money for food? Whatever it might be, so that those things are available for the individual clinical encounter. Those two things are not interchangeable in this case, I don't think, and we need to solve those problems separately.